Hello, this is Dr. Gary Siskin, and today we're going to speak about thoracentesis procedures. This is another part of my continuing In the Trenches lecture series where I'm focusing on those simple everyday procedures that nobody really ever lectures about or talks about. So I hope you can get something out of just a couple of minutes focusing on thoracentesis. I think in order to better understand this procedure, it's important to know about the anatomy that we're dealing with. The pleural space is defined by the visceral pleura, which covers the lung, and the parietal pleura, which covers the chest wall, diaphragm, and mediastinum. One of the differentiating features of the parietal pleura is that it has lymphatic stomata that open directly into the pleural space, and these allow for clearance of pleural fluid via lymphatics within the parietal pleura. These are not present in the visceral pleura. The intercostal space consists of intercostal muscles and membranes and neurovascular structures. The intercostal muscles are called the external, internal, and innermost intercostal muscles. The external muscles enlarge the thoracic cavity by drawing the ribs together and elevating the rib cage. The internal intercostal muscles decrease the dimensions of the thoracic cavity. The intercostal neurovascular bundle lies between the internal and innermost intercostal muscles, and within this neurovascular bundle, the intercostal vein is the most cephalad structure, followed caudally by the artery and the nerve. And the neurovascular bundle is located in the upper portion of the intercostal space, or just below the upper rib of the space. In terms of fluid physiology, there is normally fluid within each pleural space. Under normal circumstances, there's 1/4 of a milliliter of fluid per kilogram of body weight within each pleural space, and this fluid has two functions. First, it serves as a lubricant which reduces friction as the two membranes slide across one another during normal respiration. And second, the surface tension of the fluid couples the visceral and parietal pleura to one another, which prevents the lung from collapsing. The fluid itself is primarily produced on the parietal pleural surface and is dependent on hydrostatic and oncotic pressures in the systemic and pulmonary circulations and the pleural space, and this is dictated by the Starling equation. This balance favors some fluid moving into the pleural space, which accounts for that normal fluid. The fluid that normally enters the pleural space is resorbed and delivered back into the vasculature by way of the lymphatics within the parietal pleura. And the flow rate of these vessels can increase by a factor of 20 in response to increases in pleural fluid accumulation. So what happens when this goes wrong? Well, pleural effusions are seen when fluid production overwhelms the ability of the lymphatic vessels to reabsorb fluid because of either high production, diminished resorption, or a combination of these two factors. Increased production can be seen with changes in microvascular hydrostatic pressure, microvascular oncotic pressure, and disruption of pleural lymphatics. Fluid can also enter the pleural space directly from the lungs or mediastinum, or can pass through the diaphragm from the abdomen. Approximately 1.5 million pleural effusions are diagnosed every year, and about 175 to 200,000 require a thoracentesis to relieve respiratory symptoms and to provide fluid for diagnostic analysis. Clinically, symptoms include shortness of breath, pleuritic chest pain, cough, fever, chills, and weight loss. And these clinical manifestations are largely dependent on the underlying lung disease. There's a huge list of potential causes for pleural effusion, so the differential diagnosis is quite extensive. Most people find it helpful to divide these causes into those that cause transudative effusions and those that cause exudative effusions. A transudative effusion occurs when systemic factors cause an increase in hydrostatic pressure or a decrease in oncotic pressure across the intact capillary beds of the pleural membranes. Congestive heart failure, cirrhosis, and the nephrotic syndrome are responsible for most of the transudative effusions. They're associated with one-year mortality rates of 50%, 25%, and 46% respectively. And these effusions can usually be managed by treating the underlying condition. Exudative effusions occur when the local capillary beds are diseased, and this causes increased permeability and fluid leaking into the pleural space. The two most common causes of exudative effusions are parapneumonic effusions and malignant effusions. So I want to go over each of those specifically. Parapneumonic effusions are the most common cause of an exudative effusion, and these patients are initially treated with antibiotics. Parapneumonic effusions are part of a continuum which ranges from a simple effusion to an empyema. During the exudative stage, interstitial fluid accumulates around the infection site and crosses the visceral pleura into the pleural space. This fluid is usually sterile and will have a normal pH and glucose with a high protein content. During the next fibropurulent stage, bacterial invasion of the pleural space accelerates the immune response, which leads to further migration of neutrophils and activation of the coagulation cascade with formation of fibrin barriers and loculated pockets of fluid. And finally, in the organizing stage, which is about 4 to 6 weeks after the initial event, a fibroblastic response leads to a thick pleural peel, which resists respiratory motion and negates the efficacy of percutaneous drainage in re-expanding the lung. An empyema refers to a frank infection or pus in the pleural space, and pneumonia is the most common cause of an empyema, but other causes include a lung abscess, bronchopleural fistula, esophageal perforation, post-surgical complications, and trauma. Mortality is higher among patients with pneumonia who have an associated parapneumonic effusion than among patients with pneumonia and no effusion. Delays in drainage are associated with substantially higher mortality rates. And there is something known as the RAPID score, which can be used to identify patients at high risk of mortality or prolonged hospitalization. And this score is based on 5 variables: renal function, which is based on a BUN level, age, purulence, whether it's purulent or non-purulent, infection source, meaning community or acquired or hospital acquired, and dietary factors, which is based on a high or low albumin. There's a certain point value assigned to each of those 5 variables, and patients with higher scores, meaning a total score of 5 to 7, have a 30% chance of dying in the subsequent 12 weeks. Malignant effusions are the second most common cause of an exudative effusion. They account for more than 125,000 hospital admissions per year in the United States, with an estimated inpatient mortality of 11.6% and associated hospital charges of more than $5 billion per year. Most arise from lung cancer, breast cancer, and lymphoma, and they are associated with a poor prognosis. The median survival is 4 to 7 months, and survival does depend primarily on the tumor subtype. So lung cancer and GI cancers have the worst outcome. Mesothelioma and hematologic cancers have the best prognosis. Malignant effusions result from a combination of increased fluid production due to fluid extravasation from hyperpermeable parietal or visceral pleura and/or tumor vessels, and impaired lymphatic outflow. Post-mortem studies have actually shown that mediastinal lymph node invasion, and not the extent of pleural involvement with the cancer, predicts the presence of an effusion. These patients commonly present with shortness of breath, but lung compression is not the cause of this. Rather, it's due to a chest wall issue caused by the diaphragm being displaced caudally, which is mechanically disadvantageous for its length-tension relationship. The main mechanism underlying arterial hypoxemia is an intrapulmonary shunt, which doesn't change significantly after drainage. Fluid cytology yields a diagnosis conclusive of cancer in 90% of cases. And if cytology is negative and there's continued clinical suspicion for a malignant effusion, then a pleural biopsy can be obtained. In terms of prognosis, some people use what's called the Lent score, and this includes pleural fluid LDH, the ECOG performance status, the serum neutrophil to lymphocyte ratio, and the tumor type. And they use this score because it can stratify patients into high, moderate, and low-risk groups and can help guide therapy and predict survival. And then there's chylothorax. This is the presence of intestinal lymph within the pleural space and results from leakage of the lymphatic vessels, most commonly the thoracic duct. Iatrogenic injury accounts for about 80% of traumatic cases. Non-traumatic etiologies include cancer, infection, systemic diseases such as lupus, and congenital disorders of the lymphatic system. This is diagnosed if the fluid triglyceride level is greater than 110, and if the levels are less than 50, it means it's unlikely to be chylous. So when does IR get involved? Well, the decision to perform a thoracentesis usually depends on the size and rate of accumulation of the fluid, as well as the symptoms that the patient's experiencing. A diagnostic procedure is performed to obtain a small volume of fluid to analyze that fluid, and this is usually accomplished with a single percutaneous needle aspiration. A therapeutic thoracentesis is performed to relieve symptoms or hemodynamic compromise. The bleeding concern relates primarily to iatrogenic hemothorax from injury of the intercostal artery and not really from damage to the lung. We generally need to balance the risk of bleeding with the benefit of chest tube placement and the risk of reversing coagulopathy. And we are often faced with the question of whether or not to perform this procedure on a patient taking Plavix. This was a nice meta-analysis done on performing these procedures on patients with Plavix, and the one thing that should jump right out to you is that the risk of a major bleeding event is almost non-existent in patients on Plavix. Urgent pleural drainage can be performed safely in these patients. If feasible, though, it is best to delay the procedure for 5 days while the Plavix is withheld in order to lower the bleeding risk. In fact, major hemorrhagic complications are very uncommon after image-guided percutaneous chest tube placement in patients at increased risk for bleeding due to an elevated INR. In terms of positioning, patients may be more comfortable when sitting on the edge of the bed with their arms and head resting on pillows on a table and a footstool supporting the feet. There are alternative positions, though. Access may be attempted in the mid-axillary line with the head of the bed maximally elevated and the arm positioned above the shoulders. The patient can also be positioned in the lateral decubitus position with the effusion side non-dependent. Ultrasound plays a very important part of percutaneous thoracentesis. On ultrasound, the pleura is normally hyperechoic due to the different acoustic impedance between the chest wall and the aerated lung. The effusion is anechoic and separates the parietal and visceral layers of the pleura. The diaphragm and underlying abdominal viscera must be seen as well. I think it's important to account for these organs when determining where to access the pleural space. So in other words, I like to examine from the bottom up and make sure I'm comfortable with where the liver or spleen is located so I don't inadvertently puncture those organs. Sometimes the fluid is not anechoic, and an echogenic effusion is usually due to an exudate, although concentrated transudates due to diuretic therapy can appear echogenic as well. Swirling and floating echoes within the fluid indicates the presence of particles such as proteins, blood, and fibrin. An anechoic effusion can be either transudative or exudative. You may also see septations on ultrasound, which may be caused by exudative effusions. When we're choosing where to access the pleural space, most of the time people either use ultrasound to mark a spot or they use real-time ultrasound guidance. In general, the lowest complication rate is associated with the use of real-time ultrasound guidance. So let's talk about access. The safest place is in the area known as the triangle of safety, and this is a space formed inferiorly by the fifth intercostal space or a horizontal line at the level of the nipple. The anterior border is formed by the lateral border of the pectoralis major muscle, and the lateral border is formed by the lateral edge of the latissimus dorsi. The superior border is formed by the base of the axilla. An alternative access point is located 9 to 10 centimeters lateral to the spine in the posterior axillary line. And this is usually the position that's used when the patient is sitting in the upright position. When a tube is being placed, historically it was a very large bore tube that was greater than 28 French, and this was used in almost all situations. Today, the trend is to place small bore chest drains, including the pigtail catheters that we normally place in interventional radiology. And the advantages of smaller drains include being easier and less painful to insert, they're better tolerated once placed, and there are lower placement-related complications like lower rates of malposition, injury, and empyema. One potential disadvantage is the increased incidence of catheter occlusion with smaller tubes. And physics tells us that the internal diameter and the length of the tube are the key determinants of pleural fluid flow through a catheter. In terms of placement, the Seldinger and trocar techniques can both be used for tube placement, and this is usually determined based on operator preference and the size of the effusion. Once we obtain some fluid, we can look at it because this might be occasionally helpful in narrowing the differential diagnosis, and on this slide there is a table which kind of explains what the different appearances may mean in terms of the cause of the effusion. Most of the time we are going to send fluid to the lab for further evaluation, and the goal of sending samples to the lab is to help establish the cause of the effusion, to help guide treatment decisions, and to assess the prognosis of a patient. And one of the first steps the lab is going to try and make is between an inflammatory or an exudative effusion from those who have a transudative effusion. And generally, these are the criteria that are used. It will depend on the appearance, the leukocyte count, the pH, the protein, the ratio of the pleural fluid protein to the serum protein, the fluid LDH level, the ratio of pleural fluid LDH to serum LDH, and glucose. And using those labs, you can help figure out if you're dealing with a transudate or an exudate. Light's criteria are generally used to determine if a patient has an exudate, and it's felt that the patient will have an exudate if any one of the following findings are present: a ratio of pleural fluid protein to serum protein greater than 0.5, a ratio of pleural fluid LDH to serum LDH greater than 0.6, and a pleural fluid LDH greater than 200, or 2/3 of the upper limit of the normal range for serum LDH. These criteria correctly identify all exudates, but may actually misclassify 25% of transudates as exudates, especially in patients who have underlying CHF and have received diuretics. In this particular scenario, it's helpful to look at the serum protein or the serum albumin level relative to that in the pleural fluid to determine if you're dealing with an exudate. If the serum levels of protein and albumin are not available, then a pleural fluid protein greater than 3 or a pleural fluid cholesterol greater than 45 has been shown to indicate the presence of an exudative effusion as accurately as Light's criteria. Once the chest tube has been inserted and specimens are obtained, it must be connected to either suction or an apparatus to allow unidirectional drainage. We typically use the Pleurovac system, which is a commercially available 3-chamber water seal system. The first chamber is the collection chamber, and this connects directly to the chest tube and collects any fluid that's draining from the chest. This chamber is calibrated, so it's easy to measure the output from the tube. The second chamber is the water seal chamber. This is the middle chamber. The water seal allows air to exit from the pleural space on exhalation and prevents air from entering the pleural cavity on inhalation. Bubbling in the water seal chamber indicates an air leak. If there's no air leak, the water level should rise and fall with the patient's respiration, which reflects normal pressure changes in the pleural cavity. And finally, there's the suction control chamber. This allows you to deliver controlled suction through the chest tube. It's typically connected to wall suction, and a low-level vacuum, maybe 5 to 20 centimeters of water, is usually recommended. Increasing suction at the source will increase airflow through the system, but will have minimal effect on the amount of suction imposed on the chest cavity. People are always asking if we should be getting a chest x-ray after a thoracentesis, and there's little literature that exists to support the routine use of a chest x-ray after thoracentesis. It can be considered if the operator aspirated air, experienced difficulties, or the patient developed symptoms which are suggestive of a post-procedure pneumothorax. In time, we always have to decide whether or not we should remove a tube, and this is going to be based both on chest x-ray findings and clinical parameters such as daily output, persistence or absence of air, and whether or not it's functional or non-functional. So what can go wrong with these procedures? Well, the good news is that most thoracentesis procedures occur without any complications. The thing we think most about is pneumothorax. And the pneumothorax rate varies among individual studies from 0 to 19%. Probably the best study to look at is a meta-analysis by Gordon from 2010. They found a rate of 6%, with 34% of these patients requiring a chest tube. In total, chest tube insertion was required in less than 2% of all procedures due to a symptomatic pneumothorax. There are several mechanisms for a post-procedure pneumothorax. First, atmospheric air can be introduced with catheter removal or aspiration of fluid. There can also be needle injury to the visceral pleura, which permits air to enter directly from the lung. And lastly, there could be a rapid decrease in pleural pressure from aspiration, resulting in visceral pleura rupture. The risk of pneumothorax is associated with a failure to use ultrasound guidance, the use of larger needles, an increased number of needle passes, meaning 2 or more, and operator inexperience, although there's only a slight increased risk there compared to experienced operators. The risk of pneumothorax is not increased based on gender of the patient, the size of the effusion, the status of the patient, meaning ICU, non-ICU, and outpatient, and the use of mechanical ventilation. Once a patient is found to have a pneumothorax, conservative management is often reasonable, especially in asymptomatic patients with a small pneumothorax. If you're going to treat, a needle aspiration may be as effective as placing a chest tube in managing patients who have symptomatic or a large pneumothorax. Bleeding is another potential risk, and this is usually due to injury of the intercostal artery. Keep in mind, with age, the posterior intercostal arteries can become more tortuous and occupy a more central position within the intercostal space, and this can increase the risk of hemothorax and bleeding. Intra-abdominal bleeding can also occur with splenic or hepatic punctures, which is why I always think about that and I always look for that. Re-expansion pulmonary edema is another potential risk of a thoracentesis. This is characterized by the development of hypoxemia and new alveolar infiltrates within 24 hours of pleural fluid drainage. It's not really sure why this occurs, but increased hydrostatic forces in the re-expanding lung and direct injury to the alveolar capillary barrier may contribute to re-expansion pulmonary edema. And this is a potentially life-threatening condition with a mortality rate as high as 20%, but it occurs in less than 0.5% of patients. It's been thought that this might be related to the volume of pleural fluid being removed in a single setting. Therefore, some recommend removing no more than 1.5 liters in order to avoid this complication. However, current evidence suggests that this is probably related to intrapleural pressure, and as a result, it may be more important to avoid a decrease in end expiratory pleural pressure than the actual amount of fluid removed. Other potential complications include a sheared-off catheter, tumor seeding of the needle tract, and anxiety and site pain. Sometimes advanced treatment options are needed, especially in patients who have a recurrent need for thoracentesis. Over time, the efficacy of this procedure decreases and the risk for complications increases. In addition, there's a decrease in quality of life associated with intermittent thoracentesis, and this is another opportunity for interventional radiology in terms of performing pleurodesis and catheter-based drainage procedures. Pleurodesis is the iatrogenic fusion of the visceral and parietal pleura, which obliterates the pleural space, and it can be performed in patients with recurrent malignant or benign pleural effusions. During this procedure, a chemical such as talc, doxycycline, or bleomycin is infused into the pleural space, and this leads to pleural irritation and inflammation. Fusion of the two layers of the pleura eliminates the pleural space and prohibits the reaccumulation of fluid. Success is seen in 70% of patients undergoing pleurodesis at 1 month, but this is not a lifelong guarantee. The longer the patient lives, the more likely the fluid will return. And at 6 months, only approximately 50% of patients have adequate fluid control from a talc pleurodesis. We can talk about placing non-tunneled catheters. This is usually done in inpatients, potentially ICU patients, who need more prolonged drainage from the pleural space, especially if they're ventilated and may be difficult to wean from a ventilator. But keep in mind, they are not a permanent solution for recurrent pleural effusion accumulation. Tunneled catheters, such as the Pleurix catheter, are more commonly used in the outpatient setting for patients who have a need for recurrent thoracentesis. Tunneled catheters can be used to treat patients with malignant pleural effusions, and it has been shown to improve their quality of life. And in fact, it does such a good job that we really should be thinking about this on the sooner side, or as soon as we appreciate that a patient has the need for repeat thoracentesis procedures. Patients with non-malignant effusions requiring frequent thoracentesis can also benefit from these tunneled catheters. There are risks, such as catheter-related pleural infection. It's a low risk, and this is usually due to skin flora. These infections can start almost 2 months after insertion and are generally very mild with a low mortality rate, and they can usually be managed with oral antibiotics, and tube removal is not usually needed. Other complications include catheter tract metastases, symptomatic loculations, catheter fracture, and catheter occlusion. And finally, there's always surgery. And the decision to perform a VATS versus an open thoracotomy depends on the degree of organization and fibrosis, the patient's clinical status, and the operator preference. And surgery offers the advantages of direct visual inspection of the pleural space, tissue sampling, debridement, and allowing the trapped lung to expand by peeling the organized cortex from the visceral pleura, otherwise known as decortication. So in conclusion, pleural effusions are seen in many different conditions and can result in significant symptoms for patients. A thoracentesis is often performed in these patients because it can provide helpful diagnostic information and result in prompt symptomatic improvement. And interventional radiology definitely has an important role to play in the care of these patients.